connections that are participating in this session, and SMI is thankful that you could all find the time to be a part of today's webinar. Before I introduce our presenter, I'd like to go over just a few housekeeping items. First, all attendees for today's session are in listen-only mode in order to eliminate any background noises and to ensure audio clarity. The voices that you will hear today are my own voice and the voice of our presenter, Nate Kaufman. Although attendees are in listen-only mode, we're interested in your questions. Our webinar technology does allow for attendees to submit questions using the questions feature in the control panel. All attendees are encouraged to submit questions at any time during today's session. When we've finished the presentation, if time allows, I'll then read submitted questions and Nate will try his best to answer them. Today's session will be approximately 1 hour in total, depending upon the number of questions and how quickly we move along. The slides that you'll see today are the same as Mr. Kaufman presented at the recent SMI Fall 2015 forum, and these slides are available to SMI members from the SMI website under the forum section. Lastly, let me remind all attendees that you'll receive an email as a follow-up to today's webinar, and this is a survey request from SMI. I want to encourage you to complete the survey, as your feedback is an important component that helps SMI to continue to improve our webinar program. Now I'm pleased to introduce to you our presenter, Mr. Nathan Kaufman, a consultant, a strategist with Kaufman Strategic Advisors. With over 35 years experience, Nate is a noted consultant, strategist, lecturer, and an author on multiple topics, almost all related to health strategies for the new millennium. He's a nationally renowned expert in the areas of peak performing hospitals, payer contracting, physician groups, hospital strategy, physician transactions, integrated delivery systems, population health, dispute resolution, and virtual medicine. He's a frequent faculty member for the American College of Healthcare Executives, the American Hospital Association, and many state and local healthcare associations. This presentation by Mr. Kaufman was the keynote address at the SMI Fall 2015 forum in New Orleans just a few weeks ago, and we are pleased to welcome Nate for this encore presentation. Nate, I'll turn it over to you.
Thank you. Good morning. Let me start by giving a little background. My consulting practice, I spend a good bit of time providing strategic advice to health systems. By the end of this year, I will have visited 85 healthcare systems in the country. In my spare time, I negotiate payer contracts and also very active in physician transactions. And what you're going to hear today is somewhat of a contrarian perspective on what's going on in the healthcare industry based on my experience on the ground, if you will, with respect to the data and the attitudes that I see occurring around the country. The first slide I like to show is the fact that while healthcare is difficult for some, for us consultants, it's a wonderful time. It's raining acronyms. You hear about patient-centered medical homes, ACOs, population health, and whenever you hear that, us consultants create a practice. We've been through this before, by the way. In 1993, one of the large think tanks interviewed 1,500 healthcare, quote, leaders, and they determined that the only answer was to employ all the doctors and get ready for the most certain proliferation of capitation, none of which happened. So one of the bits of advice that I give everybody is never ask a barber if you need a haircut. The good news is actually that as I go around the country, this shift towards whatever we are shifting to is occurring much slower than the hype. And so the good news that I give my physician and hospital clients is that you can slow down and make sure that your competencies are in place before you deal with the new environment. I always ask people what the most significant event in healthcare was this year, and most people talk about the Affordable Care Act and ACOs. Actually, the most significant event occurred in Connecticut, where the governor imposed a 6% tax on all not-for-profit hospitals as well as ambulatory surgery centers, and then cut the Medicaid fee schedule by $65 million, which resulted in a $65 million cut in federal matching. So with the stroke of a pen, $450 million disappeared from the Connecticut healthcare system in 1 year. And the reason I bring that up, those of you who are in the supply business, either buying or selling, what you're seeing is huge revenue pressure occurring, especially in states with underfunded pensions. Another significant event that just happened was as a result of the new Budget Act. It used to be that hospitals could buy physician groups and then convert their ancillaries into hospital outpatient departments, which enabled them to receive about 50% more money from Medicare. The new Budget Act specifically says that any ancillary service acquired by a hospital that's located more than 250 yards from the hospital campus cannot be converted. This is the beginning of the government's attempt to restrict the amount of ancillary, or, well, to move towards site-neutral reimbursement. Again, it turns out that hospitals get paid from Medicare about 30 to 50% more for the exact same service. Another significant event happens with the drug companies who are raising their rates significantly, which again is putting huge pressure on hospitals as Medicare and Medicaid cut their reimbursement. And finally, recently the Adventist healthcare system in Florida was fined $120 million over excess physician compensation. When you pay a physician for, quote, referrals, or excess compensation, any of those referrals to the hospital will be considered a false claim and subject to treble damages. And so as you look at the healthcare system and all the attentions on the Affordable Care Act, in fact, there are a number of things that are occurring behind the scenes that, in my opinion, will have more significance in the short term. So when you hear about healthcare policy predictions and financial forecasting, and you're somebody like me who actually spends a good bit of time negotiating with physicians, my feeling is the farther you are away from the bedside, the easier it is to create your own reality. And so when you talk to the academicians and the politicians and even the system CEOs, they may have a reality about where healthcare is going that may not reflect what's really happening down at the bedside. When you look at the government's policies, they've really failed. I call it when the rubber meets the sky. You'll see links at the bottom of this where I've identified articles that show that the data behind many of these government programs suggest that, in fact, they're not working. And let me give you a couple examples. There's 408 Medicare shared savings ACOs, and my estimate is that about 45% of those actually spent more money than Medicare projected. In a Medicare shared savings ACO, the goal is to save money below the Medicare projection, and then you get half of the savings. Only about 20% of the Medicare shared savings ACOs actually were profitable, and one Medicare shared savings ACO, Memorial Hermann, actually captured 10% of all savings. So the program doesn't seem to be working. With respect to the Pioneer ACOs, there were 32 participants, and this slide is now outdated. Over 50% of the participants dropped out, and Health and Human Services still called this program a success. Also, as a function of the Affordable Care Act, 9 insurance cooperatives, or more than 9, about 12 insurance cooperatives were initiated. These are kind of not-for-profit insurance organizations in multiple states, and of those 12, 9 are now insolvent. So when you look at the government's record, we have TSA, VA, and now ACOs. These are all programs that were good ideas, but unfortunately the execution hasn't been good. And when you look at the forecasts for cost savings, I always quote John Kenneth Galbraith, who said the major benefit of financial forecasting is it makes astrology look respectable. And I'll show you that the financial forecasts don't indicate that the Affordable Care Act is actually working. That being said, I should disclose I'm in favor of the Affordable Care Act. We had to do something. So a book that I recommend everybody read is $1 Billion Lessons. It talks about great companies that have actually made some bad strategic decisions that hurt them. They say one of the big concerns is the Lemming syndrome. That is the concept that if one large organization does it, then everybody in that industry should do it. Or if your competitor does it, that means it's the right thing. To be honest, when a competitor of my clients implement an ACO or insurance product strategy, I'm actually happy, because the likelihood, as you'll see in a few minutes, is that that strategy won't work. So this is a famous New Yorker cartoon about what lemmings think. The problem, they say, with these failed strategies is groupthink. Once the CEO says it, or once the American Hospital Association says it, then it has to be right. Specific areas of failure: one is the status quo. Clearly the healthcare system is changing, and we'll talk about that. Another failure happens to be synergies, the theory that if we had one hospital and then we merge with another hospital, that we'll get huge expense savings. And in the book they say, well, there should be some savings, but reduce your estimates by 30%. If it still works, then it makes sense. But the big mistake that is occurring in health system today is adjacencies. Essentially, adjacency is the belief that an organization can sustain growth by entering a market adjacent to its core. And essentially, Bain, according to the book, Bain did an analysis of 1,850 companies and found that those that implemented adjacency strategies, and let me give you an adjacency strategy. A hospital decides they're no longer a hospital, they're a health system, and they should get into the physician employment business. And as you'll see in a few minutes, the average hospital loses about $170,000 on each physician that they employ. That's a classic adjacency strategy. Now, it's not that you shouldn't implement these adjacency strategies, it's just you need to realize that these are not extensions of your existing organization, and in fact, you need new competencies. An example of this would be the Ford Road Plant, which was established in 1920, where the idea was that Henry Ford was going to eliminate suppliers, and essentially iron ore would come in one end and a car would come out the other end. This strategy didn't work particularly well. And the big, I think, mistake that most health systems are making right now is the idea that they think they can take actuarial risk like insurance companies. About 43% of the CEOs that were surveyed said that this will lead to more fully integrated delivery systems, and only 2% said it will be a failed experiment. When you look at the actual data, Partners Healthcare in Boston actually lost $110 million on their insurance product. Catholic Health Initiatives lost $23 million. Long Island Jewish lost $12 million. And I have to give credit to Piedmont Wellstar in Atlanta. After 3 years of losing tens of millions of dollars, they got out of the insurance business. Now, you'll hear from some of these folks, well, it will get better next year. However, the evidence doesn't support that. Henry Ford's been in the commercial HMO business for many, many years and loses $12 million a year. One other point, many hospitals that are health systems that have their own health insurance product actually become their worst payer to avoid that health insurance product from operating at a deficit. So it's simply a transfer pricing strategy. So the challenge we have is the same challenge as this doctor, which is to say to a patient, if you don't change what you've been doing for the last 40 years, there's a high probability that something bad's going to happen in the future. I don't know when, and it's not so for certain, so change. And of course, the patient says, what's with all this doom and gloom right now? I feel great. It turns out, by the way, from a physician's perspective and a healthcare perspective, high caloric intake, obesity, and lack of physical activity will surpass tobacco as the leading cause of cancer death within the next 2 decades. The reason I put this up, number one, is because we can't count on wellness, but even more significantly, our challenge is to convince healthcare systems, or my challenge is to convince healthcare systems, suppliers, and others that they need to begin the process of changing, or there's a high probability something bad's going to happen in the future, but it's not for certain. Some of you will view this as a doom and gloom presentation. It really isn't. It's just the healthcare industry is very simple math. It's revenue minus expenses, and as you'll see, there's challenges to both. So what we have in healthcare today is what's known as the tragedy of the commons. And the boring definition of that is a tragedy resulting from the depletion of shared finite resources by individuals acting independently and rationally according to one's own self-interests. But this was a concept that was developed by Derek Hardin, an economist in the 1960s, when he studied colonial times in Boston. And there was a thing called the Boston Commons, which was essentially a free pasture. And all of the people that had herds of cattle would go and graze on that pasture. Since it was in everybody's self-interest to build their herd, they did. But there was a finite resource, which happened to be the pasture. And eventually, they would overgraze the pasture, and there would be a tragedy of the commons. There were really two options. One option was that everybody got together, and there was kind of mutual sacrifice. The other option would be that in order to mitigate the tragedy, the government would have to step in and impose regulations. And so as I look at healthcare, the question I ask is, who's going to volunteer for a reduction in income? And if the answer is nobody, and that's probably true, then the likelihood is that we are in for more tragedy. And as a result, the government's going to increase their regulations. We also see the tragedy, by the way, with respect to capital in health systems, where there is a finite amount of capital and everybody is trying to get access to that capital. Again, the issue is that the CEO comes down with regulations and really limits the amount of capital available, which really is a change in the traditional buying habits. When you look at healthcare, everybody's talking about primary care as the reason that, why that's doing that, a reason that we will be able to control cost. It turns out that according to the data, about 80% of all healthcare costs are actually influenced by specialists. So approaching specialists is still a major strategy for suppliers. The challenge is that these specialists have all merged. So while you used to have 3 orthopedic groups in a market, now you have 1. And because they've become an oligopoly or a monopoly, they're not particularly interested in volunteering for a pay cut. So their orientation, because I represent a number of them, is to demand fee-for-service, which is why taking actuarial risk will fail, because the 80%ers aren't particularly interested in saving money and reducing their utilization. So as I look at healthcare systems, many of these specialists aren't particularly aligned with where the health system believes they should go. And when they're not aligned, they're going to fail. One of the rules that I use, or 2 rules that I use, is in order to move to a new delivery model, you need to have practicing physicians leading the initiative, and you need to give them valid data. And in the few places that have been successful, both of those situations are true. So when you look at a healthcare system, it's really a fairly simple formula. That is, they have to demonstrate to bondholders that they can generate cash. When they do that, they have access to capital at a reasonable interest rate. And then what they're able to do is purchase the equipment and build facilities they need, but even more significantly, they have a new responsibility, which is to stabilize physician incomes. As I mentioned earlier, the average employed physician is now costing a hospital $176,000. This is a whole new component, and it's really consuming much of the funds that used to go to pay for supplies and other services or other components. And so when you look at what's behind the curtain, it turns out that with all the talk about affordable care and patient-centered medical homes, what's driving the success of most health care systems continues to be negotiated commercial rates. Government reimbursement is declining, volume is essentially flat, And those facilities that are reporting profits and record profits are doing so because they're able to negotiate superior rates with the insurance companies. Those rates, by the way, are driven by market share, not value. So when you look at markets like Boston, it turns out that the healthcare systems that have the most profitability are those that have the greatest volume. After commercial rates, personnel costs represent about 50% of the revenue of a hospital, and then their supply costs, which currently represent about 18%. And as there's revenue pressures, there's more attention on supply costs, especially physician preference items. The other big area happens to be capital spending. Now, once you get your supply costs, your personnel costs down, the only thing that's left is to reduce the losses from your employed physicians and then improve clinical efficiencies. A key component of improving clinical efficiencies is standardizing the use of expensive supplies. To give you an idea of how crazy our market is today, these are actual negotiated rates. This is what's known as a cost per episode. They include the institutional fees, which are negotiated, which represent about 70% of the cost. You can see, for example, a hip replacement, it costs about, in Massachusetts, it costs about 4 times as much to get it in one facility as it does in another facility. And again, that is totally driven by market power. My belief is that over time, probably not in the next 2 years, maybe in the next 5 years, this is going to become more rational. By the way, if you look at Chicago, the highest negotiated rate for an angioplasty probably is with a healthcare system that's bragging about the fact that they have a clinically integrated network and a shared savings program. Again, if you look at that healthcare system, what continues to be driving the profitability happens to be premium negotiated rates. And so while there's a lot of talk about volume to value, really what's driving the healthcare systems is market share and negotiated rates, which, by the way, is why the insurance companies are trying to merge so that they can get stronger and hammer the providers and reduce the rate increases. So what I tell every healthcare system, physician, healthcare company is develop a point of view. I have a point of view on the market in terms of how it's going to change and what you need to do to be successful. Some people agree with it, some people don't. But here are the questions to ask. Healthcare is local, and the question you need to ask is, what will the local market look like in 5 years? Just for example, the state of Georgia, the Atlanta market is going to accelerate in terms of change. We're already seeing mergers and other things. Meanwhile, Albany, Georgia, it's going to be a long time before you see any changes in that market. And so you have to understand the local market and market pressures. What competencies do you need, and can you develop them? Again, there is a school of thought that one of the competencies that we need in healthcare is to take actuarial risk, insurance risk, but the fact is, according to the theory of adjacencies, most healthcare organizations won't be able to develop them from scratch. What's the industry's conventional wisdom? Have we seen this movie before? And I would argue that we have. What are the financial implications without heroics? I've seen pro formas that show that if we just started an insurance company and enroll 100,000 people within 2 years, we'll be wildly successful. But that's not the case. And the most important thing, does the practicing physicians have a common understanding and commitment to what is commonly referred to as population health? I gave a presentation to about 400 CEOs last year, and I bet if you asked each one of them what their definition of population health is, you would get 400 different definitions. And so we can't even come up with common definitions for these new innovations, and yet people think that they're going to be necessary within the very near future. This is what I tell my health system clients, and really is the most important slide that I have, which is We talk about value, but there's not a particularly good definition. I define value as a benefit, perceived benefit per unit price, and if the benefit is worth the price, then the healthcare system or the consumer is going to buy that service. The question I ask is, how are you going to be differently better in the eyes of the customer? Because if you're not differently better, you're the same. If you're the same, you're a commodity. This is true with supplies as well. We've seen historically, and I would argue with the exception possibly of IT, where we've seen this historically, that if you are a, quote, brand name, that people would automatically want to buy your service. And now what they're doing is looking much deeper to determine if in fact you're differently better, and if you're not, they view you as a commodity because they have to reduce supply costs. For healthcare systems, there's 4 components. There's providing appropriate care, getting optimal outcomes, providing great service, and access. As patients, we will switch providers based on service and access. That's how we brand. But when you look at if I were a supplier, which I am, to a healthcare system, essentially my question is, how will this product improve appropriateness, outcomes, service, and access, and do it without significantly increasing the cost of care, in fact, hopefully reducing the cost of care. So my advice to health systems is you need to do 2 things. One, you need to measure. Kaplan and Porter did a study. They asked every hospital, how much does it cost to do an appendectomy in their facilities? They then went in and brought stopwatch nerds to measure the actual cost. On average, the hospitals were 30% off. And elimination of waste is the buzzword in the healthcare systems today. So again, the selling proposition for any product or service is improving appropriateness, outcomes, service, and access, and eliminating waste, and facilitating or being able to provide measurement of cost and these various benefit components. So what is population health? I get a chuckle from this slide when I show it, but when you think about it, what happens is these 2 people sit in the exact same waiting room and get the exact same service from an internal medicine physician. The concept of population health is to segment your population and then design a delivery system for that specific segment. So a high-risk diabetic isn't going to their primary care physician, to their diabetic specialist, to their podiatrist, to their ophthalmologist, and making their own appointments. Essentially, once a high-risk diabetic is recognized, then what happens is they enter a delivery system that provides coordinated care from all of those sites. So it's no longer a fend-for-yourself delivery system, but a delivery system designed around the needs of a particular segment of the population. So what are my observations thus far? Number 1, population health is not about economics. It's a delivery model, and it's designed, again, around a subsegment of the population. We talk about bundle payments like they're new. We've had bundle payments since the 1990s. They're called DRGs. They essentially bundled the services provided in an inpatient environment. The new bundle payments add 3 days prior to admission, 30 days post-discharge. But when you look at how health systems have done with what I call bundled DRGs, the average healthcare system loses about 12% per DRG, and as a result, we haven't even been able to bundle or successfully bundle within the 4 walls of our hospitals. The key question is, what is risk? And there's 2 components of risk. There's performance risk that says if you do these things well, you'll get a bonus. If you do these things poorly, you'll get a penalty, versus actuarial risk, which says here's $450 per member per month, you take care of the patient. My point of view is that we're moving to performance risk. A bundled payment is a performance risk. A Medicare shared savings payment is a performance risk. And so the question is, how do you prepare for performance risk? Again, I'm not particularly bullish on actuarial risk. And again, to the extent that you're a supplier and can show a health system how you can improve their metrics for performance risk, the more they're going to be interested in your service and products. Another big problem that exists in health systems today is they're merging, but they don't know how to operate a multi-facility system. I just finished a radiology strategic plan for a health system where they have 5 different radiology groups, 5 different ways of doing things. Each group buys or recommends their own equipment and their own pharmaceuticals, so there's no economies of scale, and there's 5 different contracts. And so one of the keys to being a successful health system is to identify what needs to be standardized and what needs to be left to the regional to the regional leadership. The other thing I mentioned earlier is specialists. We can't de-emphasize the importance of specialists. They are the ones, by the way, that are using most of the supplies that you sell to healthcare systems, and to the extent that you can help them define value and demonstrate to the leadership of the organization there's value, the more likely they're going to be interested in purchasing your services and supplies. There has to be a downside in any of these physician organizations for them to participate. There are ACOs that are now getting paid 20% better, or their physicians are getting paid 20% better when they participate than those that dropped out and are just community-based doctors. It turns out that fear of loss motivates physicians much more than upside potential. And with that, unfortunately, most organizations are focusing on giving physicians a bonus, and it turns out the evidence is that's not changing their behavior. And finally, organizations aren't strategy. What I advise health systems is, how are you going to be measurably differently better over the long term to provide value to your customers? I also advise them that the key measurements of success are market share and profits. This is kind of Michael Porter's theory. A lot of these health systems are talking about their growth in terms of admissions or outpatient visits, but their profitability is declining, which in my mind means that they're failing. So when you look at all of these things that we've had now for the last several years, from value-based care to wellness, it turns out that our nation's healthcare costs continue to escalate, much of it driven by pharmaceutical costs at this point. And so as I, again, prepare my clients for the future, my belief is there has to be another disruption in the healthcare system, because one of the things the Affordable Care Act has not been able to do is to reduce the cost of care or the nation's expenditures on healthcare. When you look at some of the components, Medicare, according to the former chief actuary of CMS, Medicare will spending will grow faster than projected. He believes Congress will have to step in. And the reason is, every hour 400 baby boomers turn 65, and we consume a lot more cost than those under 65. In order to deal with this, the average Medicare patient has about $65,000 in savings, which they can use to buy supplemental health insurance, or they can simply enroll in an HMO. And now 1/3 of all Medicare patients are in HMOs. The government cannot start the fiscal year without knowing how much they're going to spend on Medicare. And by encouraging people to go to Medicare Advantage plans, they're going to be able to cap their expenditures. The fastest growing health plan in our country, grew 18% last year, was Medicaid. And if something isn't done for Medicaid, it's going to double within the next decade. What most states are doing is delegating their Medicaid program to managed care. That's going to put increased pressure on hospitals and health systems as the managed care Medicaid plans try to restrict reimbursement. And if you look at the government's expenditures, you can see that they're projecting, even with their conservative projections, that healthcare costs are going to continue to rise exponentially. And again, all this means is we're in for disruption. If we prepare for it, we have time, we're going to be just fine. On the commercial side, this is your typical family of 4. They make $51,000 a year. They have $2,300 in savings. They're expected since 2006 to pay, their deductibles have gone up over 100%. Their contribution to their premiums has gone up 72%, and their earnings have only gone up 23%. And so, in fact, the exchange plans typically have an $8,000 deductible, which these families of four cannot afford. So the theory is if you have a high deductible, you're going to shop for health care. The evidence is that almost a third of the patients who have health insurance have an unmet need due to affordability. If you can't afford a $1,200 MRI, you can't afford a $550 MRI. What they're doing is they're skipping care until they get really sick, and then they're showing up in the emergency departments as train wrecks, and then they stiff the hospitals for the deductible. So this kind of reminds me of the housing bubble, where we gave people a benefit and expected them to pay us back. What we're doing in healthcare is exactly the same thing, and in my opinion, it's not sustainable. As a supplier to hospitals or a purchaser of supplies, this is the most significant impact from the Affordable Care Act. Traditionally, the hospitals had tons of money. Whenever anybody needed money, they could go to the hospital. Whenever the hospital needed money, they'd go to the health plans. And then what the health plans would do is raise their rates 20%, and they'd lower their benefits, increasing copayments and deductibles, and they'd kick out all the sick people. That is the traditional way that we've been able to essentially compensate for underfunded government programs, and also to compensate for inefficiencies within our delivery system. As a result of the Affordable Care Act and the aging of the population, hospitals can, or insurance companies can no longer raise their rates like they did historically. There are standard benefits. You can't kick out the sick people. And so the primary way that we've been able to fund our inefficiencies is really over. So one of my key points of view is that we're going to see lower revenue growth and huge pressure on revenue over time. To give you some idea, commercial volumes are flat, and the average not-for-profit hospital is getting about a 2% increase from the commercial insurance companies on a year-over-year basis. To show you that impact, and this isn't particularly wonderful news, this is from a company called Altarum, A-L-T-A-R-U-M, which produces this producer price index on a monthly basis. Just to give you an idea, from 2002 to 2003, if you provided a service in a hospital, and this is blended Medicare, Medicaid, and commercial, on average the hospital would get a 5.8% increase. Today it's 1.3%. So again, we can't count on price as a mechanism to compensate for our inefficiencies. So while you hear this concept that we're moving from payment for volume to payment for value, as someone who negotiates managed care contracts, my response is, oh really? Actually what's happening is that the payers are using value as a reason to pay all providers less. However, those payers continue to achieve record operating or profit margins. And so the money is essentially shifting from the reimbursement to health systems and physicians to payer profits. And as I mentioned, this concept of performance risk so far is really conformance risk. In other words, are you giving a patient aspirin when they come in with a chest pain? Those are the kinds of questions upon which bonuses are being provided. So again, the insurance companies say, well, we used to give you an 8% increase, now we're going to give you a 2% increase, and if you do these three things, we'll give you another 1%. What I tell my health system clients is that what really matters is regional market power. That's what's driving payment rates. And I would argue that it's not having a national chain. If you have the second or third tier hospital in 20 markets around the country, that's not going to help you in terms of getting your fair share of the insurance premium. When you look at what HCA has done, which is a high-performing healthcare system, if they're not first or second in a market, they exit. that market. So what's my strategies? Well, one of the big new emerging strategy or areas of healthcare is virtual medicine. I received this email last year. What it said is essentially I'll be able to FaceTime with a physician, a board-certified physician, typically within 2.5 minutes for $49. And in my case, it's actually reimbursed by the payer. Who employs these physicians? It turns out that my insurance company does. And so we talk about CVS as being the new delivery model and those kinds of things, but really virtual medicine is the future. In fact, Apple is working with many of these virtual medicine companies to try to extract vital signs from your Apple Watch and send them directly to these virtual providers. Now you can actually get a complete dermatology visit online from the comfort of your own home for $59. You can get a next day appointment from the Cleveland Clinic based on an initial virtual visit. And if you take a look at organizations that are on the forefront of performing in the new health delivery market, Kaiser will probably, their virtual visits will exceed their office visits probably before the end of the decade. Even Mass General is experimenting with virtual e-consults. This is a company called American Well. These are their clients. Those of you who think that virtual visits are going away, they're just going to get bigger. In fact, Amwell just signed a national deal with all of the Blue Cross plans. And so regardless of whether the health systems get into the virtual visits, they will be probably in every market. My belief is where we're going with respect to reimbursement is tiering. What tiering basically says is that if you go to what the payer categorizes as a Tier 1 provider, your copayment and deductible will be less than if you go to a Tier 2 provider that is perceived to have either lower quality or higher cost. This is a slide I stole from United Healthcare. They've identified 71,000 doctors in 41 states as Tier 1 providers. And they based that on appropriateness. Again, one of the benefits we talked about. They also identified 36% of the specialists. And they did that based on their willingness to avoid duplication, meaning they're willing to reduce waste within the system. To give you an idea of the results, and they have an excellent control group that is Tier 1 and everyone else. If you just look at knee replacement, they've been able to reduce the cost of knee replacement by 26%, 17% lower complication rates, and 41% reduced redos. Now the reason this is important is because the insurance companies are not looking at per unit pricing any longer. They're looking at the cost per episode of care. So if you can reduce the cost per episode of care or help a hospital do that, even if they have premium rates, the insurance companies may consider them Tier 1. In Southern California, the teachers' unions identified Tier 1 providers, and within 2 years, 85% of the teachers have selected Tier 1s. One other point why tiers are so important, it doesn't exclude anybody from the network. You just have to pay more. So if you have a large female workforce, you're able to say to that workforce, you can continue to go to your OBGYN and you can continue to use your pediatrician for your kids. They're not excluded from the network, which is very important, especially for large employers. The government is really getting into the performance risk business. Right now, the average healthcare system, 7% of their Medicare reimbursement is at risk. And these are the characteristics that they're using for the measures they're using for 2016 for how they're going to measure performance risk. I just picked a couple hospitals at random, and you can see that many of these hospitals, many of these prestigious hospitals actually did fairly poorly in performance risk. Virginia Hospital Center is in Arlington, Virginia. It's a standalone hospital. It has excellent performance risk results. However, it gets paid probably the lowest rates in its market compared to Inova, which is a large 5-hospital system. So the interesting phenomenon is there's no correlation between what a hospital gets paid from the commercial insurance companies and what their performance risk results is. This just reemphasizes the importance of market power. Now, the government program's great except for one thing. They have no apparent change. They have had no apparent change in quality of care trends. And so while we are being subjected to performance risk and other factors, it turns out just like ACOs and Pioneer ACOs and many of the other government initiatives, it has had very minimal to no impact on cost or quality. The ACOs, here's the results for the last couple of years of ACOs. The progress towards cost stabilization, which was their primary focus through ACO contracts for Medicare and commercial PPOs, has been modest at best. The National Association of ACOs said the financial results in 2014, which were reported this year, came as a disappointment. And finally, these articles, again, you can look them all up, Medicare yet to save money through heralded ACO medical payment model. It turns out that the only thing that's working with respect to reducing Medicare costs is converting admissions to observation days and paying less. That is just redefining a short stay admission to an observation day and having minimal increases in Medicare reimbursement. So what are some of the organizational competencies that a hospital needs? Well, if you look at a hospital and you have multiple physicians in a given specialty treating the same patient, what you find is that there may be 4 or 5 different ways that that patient is treated. For a cardiology patient, that's pretty scary because the American College of Cardiologists said somewhere in the neighborhood of 12% of all stents are inappropriate. Deming, the father of the quality movement in our country, said it best that to reduce my message to achieving excellence, it all has to do with reducing variation. So when I look at who's being successful, Kaiser had, in fact, about an 8% profit margin this year. They get the best ratings, and the reason is they're an organized delivery system. They comply with hundreds of clinical guidelines, and they're all connected by the same electronic health records. On the other side of the equation is what I call a coalition of competing self-interests, which is essentially a culture of optionality, autonomy, and silos. This, again, we took advantage of these optionality, autonomy, and silos when we sold to hospitals supplies in the past. And now, in order to reduce clinical variation and to reduce cost and waste, the health systems are moving towards single physician preference items, or no more than 2. So just to point out, and I'm moving a little bit faster now, the point here is that 31% of all Medicare programs are in HMOs, and when you look at the top 10 HMOs in the country, most of them are Kaiser. So the point here is that I tell health systems that you have to become more Kaiser-like in your efforts. When I look at most health systems, what they can guarantee me is that my care will be no worse than that provided by our least competent physician. I always stop in my presentation and see if anybody wants to push back on this, but nobody does. The other point is that most health systems can't guarantee that my care is going to be appropriate, efficient, state-of-the-art, or meet the highest professional standards. So what I ask hospitals and health systems to do is forget about the Affordable Care Act and just think about patients and think about the fact that regardless of where I go in a system, I should consistently get superior service, predictable, reasonable cost per episode, and appropriate, accessible standard care based on the best science of medicine. And if they do this, and they're geographically indispensable, they will be able to get their fair share of the premium without getting into the insurance business, and they'll be able to provide great care to their patients. Now, it's not just being big. I just did some research again on Henry Ford. Their credit rating was downgraded. They've employed hundreds of doctors. They're one of the largest health systems in the state of Michigan, and yet their credit rating was downgraded. Catholic Health Initiatives on $14 billion lost $641 million last year, and then even Partners reported a $22 million loss on $11 billion. Why? Because some consultant must have convinced them to get into the insurance business. And so how do you create a value-based network? Again, the focus should be on cost per episode. If I want to get a hospital's or health system's attention, I want to talk to them about reducing cost per episode, not unit price. They need to have a mechanism to measure cost and outcomes. And if they do that and they focus on this value-based network, they will actually reduce the cost of their employees' health care, and they will also achieve bonuses from the various performance risk plans. They need to be geographically indispensable, have centers of excellence. That's all about documentation. And I'm just going to move on. The point here is this, that the key to change, and this is from Chip and Dan Heath's book called Switch, is you need to have a rider and an elephant. The rider has a long-term view looking over the horizon. The elephant is a subject of their training. And if you look at in most health systems, the rider is us suits who are looking over all the new things and reimbursement trends, and the elephant, of course, is the medical staff. And the question is, how do you get the elephant to move towards a value-based network? Well, there's two things you need to do. You need to make it easy. Physicians will not change their workflow unless there's a huge incentive to do so. So rather than trying to create an incentive, you're much better off trying to develop a process whereby there's minimal change in physician workflow. And the second thing is to start small and show small incremental results, and that leads to credibility. Many health systems went out, created these giant ACOs. They've had no impact on anything. The physicians have not gotten any bonuses, and so they've burned their political capital. The secret in this business happens to be not hiring a consultant, but data and peer leadership. If you want to find a program that's working in our healthcare environment, an innovative program, it's again because of the physicians leading the charge and being given good data. So just to summarize a couple points, and then I'll end within the next 5 minutes. The status quo is not going to work, but also being too bold isn't working. The key to this business is continuous measurement and incremental improvement to become differentiated in the eyes of the customer, to be differently better. And the two key components of that are actionable clinical analytics, so you can improve appropriateness and outcomes, and accurate cost accounting so that you can eliminate waste. So the rules to value are as follows. Healthcare is local. You need to develop tools to accurately measure and report appropriateness, outcome, service, access, and cost. And if you're going to sell to a hospital or health system, you need to be talking about those things. Watch out for the Lemming Strategy. Don't get ahead of your competencies. Eliminate waste. Avoid using heroic assumptions. Explore the Medicare Advantage space, probably partnering with a health plan. Measure success in terms of market share and profitability. Ensure that you're geographically indispensable. Don't trade deep discounts for the promise of increasing market share. It's not happening. And organizations and buzzwords don't create value. Value creation requires physician leaders and their followers. I'm going to skip this slide here and just briefly talk about Memorial Hermann. They created a network made up of or led by practicing physicians. There's 3,500 participants in 7 hospitals. Once these small committees of excellent physicians called CPCs come up with a clinical guideline, they're able to implement those guidelines in 7 hospitals. They have over 600 guidelines with about 80% compliance, and as a result, the insurance companies are approaching this network to contract with them, even giving them increases in per unit reimbursement. And also, as I mentioned earlier, they got the single biggest payout from the Medicare shared savings programs. So the fact is this thing can work. However, it requires a data system and physicians, practicing physicians. Just one example of this is they wanted to reduce maternal deaths And what they did was require that anybody in the network, any obstetrician or nurse, had to take 22 hours of mandatory in-service. If they didn't, they were not allowed to deliver babies. They would have to drop out of the network. And if they did, they would take a 20% cut in pay because the network got premium rates. These are the kinds of things that need to be done to create a value-based network. Now, you don't have to believe my point of view. In fact, my hero is Gary Schilling. He said the housing boom would soon go bust, and it will affect everyone. Of course, the National Association of Realtors didn't buy Gary's point of view. They said all that doom and gloom forecasts are not only irresponsible, but downright wrong. The fact is that strategists can predict what's going to happen. We just can't predict when. I got this email from a friend. He said, Nate, stop, take a look at what you become, look in the mirror, look hard, you're real down, or get a grip, rise above the hate, really man up, money to be made. So I'm going to skip the bad news. You've heard enough about that, so let me just mention the good news and then finish. More people are covered by Medicaid and private insurance, which is essential in the richest country on the planet. It's disgusting that many people didn't have insurance. We're now beginning to measure outcomes, appropriateness, service access, safety, and waste. And there's some movement towards holding people accountable for it. Payers are now forming data consortiums and providing data to providers in areas of cost per episode of care. There's a small group of providers that actually can demonstrate better value at this point. Insurance premiums are being capped, which is good for me as an employer, not good for the providers who used to rely on large increases. The electronic health record has become the standard. Unfortunately, it's interrupted physician workflows, so they're not thrilled. Innovative technologies are emerging, like virtual. We're beginning to understand the true cost of care and its relationship to outcomes. And it used to take 17 years before a medical advance would be considered common clinical practice. And now the specialty societies and medical societies are accelerating that process. So just final slide is this. The future's here. It's just unevenly distributed. You'll notice I didn't talk about any theory. I didn't look at this from an ivory tower. In fact, just the opposite. What you see around the country is a move towards performance risk and the fact that costs haven't been mitigated due to the aforementioned tragedies that were experienced. We have to catch our confirmation bias, the fact that as the data comes in, even though it may disagree with our beliefs, we have to accept the data. And the data suggests there's going to be huge revenue pressure over time. This data also suggests that much of the excess capital that hospitals have had traditionally is now being diverted towards physician employment. We've heard this bed rental prediction before. My belief is that the hospital business will continue to be a good business. It just needs to consolidate. If you look at markets like San Diego, the premium health systems are actually still generating benchmark financial performance. And I'd like to remind people this, that last year Norfolk Southern Railroad made $2 billion. Just like the railroads, we're not going to be obsolete. We have to do a better job of managing, and ultimately that's going to mean clinical standardization, which is going to take some time. Last point I'll make is don't let this be your Kodak moment. The fact is the industry is going to change. The great news is that we have time, so I'll end with the point that if you don't change what you've been doing for the last 20 years, there's a high probability something bad's going to happen in your future, but I don't know when, and it's not for certain. That's my pitch, and I'll be happy to answer any questions. Thank you.
Nate, this is Dennis Orthman. That was fantastic. Thank you. I know we've got just a couple of minutes left, and had a number of questions come in, and I don't know if we'll be able to cover them all, but let me pose one to you here. One of our participants on the webinar said, is the CVS model with on-site clinics an example of a successful adjacency strategy?
It's a great question. Actually, from what I understand, CVS is losing money on those strategies, and what they're doing is they're bringing you in to buy toilet paper and paper towels and cough medicine and other and get the pharmacy revenues, and that it's somewhat of a loss leader. So again, the question is, and by the way, I think CVS's profits have gone down a little bit since they stopped selling cigarettes, which I think is a good thing that they did that. The point is that at this point in time, I believe it's a short-term strategy. I'm not seeing that it is directly profitable, and I think it's going to be overcome by the virtual visits that we're beginning to see grow over time.
Great. Nate, we've got one more good question for you. There's a bunch of them submitted. How do you see the healthcare bubble bursting? How will that play out in your mind?
Well, what I believe is that there's going to continue to be revenue pressure. The biggest issue that I see is that Medicaid, which again is the fastest growing health plan in our country, the Medicaid patients are not getting access to specialists who are expecting to get paid 150% of Medicare to see patients, and Medicaid pays them about 60% of Medicare. So the government's going to have to respond. If I had to bet, I would say we're going to move towards the Maryland system, which is regardless if you're Medicare, Medicaid, or commercial, the providers will be reimbursed the same rate. So it will be not single payer, but a single rate system, and then it will be up to the payers to differentiate themselves. Again, the issue becomes there's going to be revenue pressure, and more the focus will be on for everybody on value.
Great. Nate, thank you so much. I'll remind everyone these slides from this encore presentation by Nate are available on the SMI website for our members under the forum section. And Nate, I want to thank you for sharing with us again. And I know you sped up your presentation a little bit here to fit our 1 hour time frame, so I very much appreciate that. And I want to remind everyone here that they will be receiving a very brief survey email later today, and we encourage you to take that so we can get your feedback. With that, we'll adjourn today's session. Nate, again, thank you very, very much, and thank you all for attending, and we appreciate your participation in these SMITU webinars. Thanks, everyone.
My pleasure. Bye-bye.
Bye-bye now.